Уважаемые коллеги, тогда с
Dear
вашего
colleagues,
позволения мы начнем
with your
следующую
permission, we'll start
презентацию.
our
Это
next presentation.
определение случаев туберкулеза и перспектива мониторинга и оценки.
This is detection of cases,
Эту тему вы
evaluation and
все
monitoring.
прекрасно
Of
знаете,
course,
владеете.
we all know this topic
Мы
quite well,
постараемся, чтобы
and we will try during this presentation to give you some definition of cases that are used for quite a while, those that have changed recently, and the future changes that are planned. So currently, we use the definitions of cases and their treatment outcomes. As you all know, and mainly we have representatives of programs here who basically monitor and evaluate the programs. In our countries, we use and are guided by those documents listed on the slide, and they help us in determination of terms and cases. You perfectly well know the framework document of WHO. This is the definitions and reporting frameworks that has been revised in 2013, and then it was updated in 2014 and 2020. We also see here links to these documents. In addition, in 2020, we had two big meetings organized by the WHO. They were advisory global meetings, first for revision of definitions, and the consultations on treatment outcomes. So the terms that we use for definitions and reporting and monitoring and evaluation, they're based on those resources. We also give you the info that you may know. In June 2023, the new updated guidance on TB surveillance is going to be issued. And it will have the reasons and the rationale of why it is going to be published, and one more revision of definitions of cases and treatment outcomes. That happens because we wanted to be in accord with the global strategy. Well, in 21, 22, and 23, the treatment protocols and guidances were revised from the point of view of diagnostics and treatment, and also based on results of more than 100 national epidemiological reviews in those years since 2013. Some gaps and problems were identified from the point of view of monitoring and evaluation and definition of cases, and therefore this new guidance will have solutions for the identified gaps, and also to facilitate individual registration electronically. And of course, there is the increased need of real-time data. So we need data right now today, which describes the current situation Yeah, we need to know what is the situation today and not in 1 quarter or 1 year. And for that, the WHO decided to update the guidance on TB surveillance, which we don't know yet. Very much we hope that we will have this opportunity very soon. But before that, let's go through the definitions that you know very well, just to remind ourselves, just to remember what are the nuances or elements in those definitions, and probably will add new knowledge about the updated definitions. And I'm sure you have information about that. Now, where does it start? First, we speak about the verification of these cases, and we know that bacteriology confirmed TB case. So this is the first one, and this is the case where the biological specimen is positive by smear microscopy culture or WRD, such as 𝗔𝗋𝗋𝗿 or well, TrueNet, maybe we don't use it in our region, but it is also advised and recommended as the rapid diagnostics facility. And all such cases should be notified regardless of whether TB treatment has started or not. So when we talk about the confirmed cases, so before countries started introducing molecular and genetic methods, the countries considered it the positive microscopy or the positive smear, and now it can be the case negative on, say, on microscopy but if it's the gen expert confirms it, then it may be considered as the confirmed case. And the reason why we have such a low level of confirmation is that maybe because not all countries report about not all countries report about the confirmed cases at the molecular level. Maybe they are negative on microscopy or something else, but if it's the positive on gen expert and treated before, we have to consider as the bacteriologically confirmed. Now, clinically diagnosed cases, this is the one that doesn't fulfill or doesn't meet the criteria for bacteriological confirmation, but has been diagnosed with the active TB by a clinician or other medical practitioner who has decided to start the full course TB treatment. This definition includes cases diagnosed on the basis of X-rays, abnormalities, or suggestive histology, or extrapulmonary cases without laboratory confirmation. However, if during treatments, those clinically diagnosed cases without bacteriological positive results, if they are confirmed by a gen expert or smear microscopy or culture, etc., if that identifies them as positives, then they should be reclassified as bacteriologically confirmed. So it could be cases that they were clinically diagnosed and confirmed, but during treatment by any method that we use, and if we get the positive results as a result of treatment, that case should be considered as bacteriologically confirmed. The reasons may be, say, the materials that we've taken in the beginning, when the samples were not of a high quality, etc. So such cases are probably very rare.
как бы подтвержденным должен был бы быть, но на лечение, наверное, она уже не будет. Но если у нас будут такие случаи, мы должны их перерегистрировать.
So if we have cases like that, we have to reclassify them and we should consider them as bacteriologically confirmed. What does it mean for monitoring? And so if some samples are taken in the third month of the treatment, and of course, not always these materials cover the whole, they do not contain all information for monitoring. And plus, not everybody has the so-called instructions that if we have some results on the third month, then we have to go back to the first page of our database and re-register the patient or the case as a bacteriologically confirmed. So we have some cells where we registered cases. We have to change the status of the case, and we have to identify that it is confirmed by GenExpert or some other method. Our systems are not extremely flexible and they may not be giving all these opportunities, so we need to change our systems. It may be a gap in our systems, and therefore we need to think how we deal with this problem so that we ensure that all cases that were confirmed by labs during the treatment, so that they are not that they do not remain as unconfirmed, so that we can actually account all these cases. We need really the full inventory of cases. Can I ask you a question? Yes, please. So if the case is negative in the beginning, then it becomes positive, and say we treat it and for 4 or 5 months, will it be considered as the failure? When we talk about the treatment outcomes, according to all definitions, well, if it is a sensitive patient, then the outcome is basically not successful. But right now we're talking about the definition and bacteriologically confirmed case, but it will be as the failed bacteriologically confirmed case. The question, so if we have basically the failure, then we will have the second episode of treatment, and then it turns out that we had the first not confirmed, but the second episode bacteriologically confirmed, and then it will be considered. So what I mean is that correct is it? So if we confirm it post factum and we make some estimates and calculations and the new episodes that if it's in the second month, then there shouldn't be any outcome. Yes, it is a very interesting discussion. And in fact, it's all about the new definitions of the treatment outcome. Before that, we were waiting for the 5th month. And this is sort of a key month to identify, because if in the 5th month it's still positive, then the treatment would have been considered as unsuccessful, and it would have been, considered as too late, that we waited too long to identify whether the treatment is successful or not in case of the sensitive tuberculosis. So now we will see the new definitions of outcomes, and we'll see that in cases where even in the second month remains positive, and if there are some additional increased resistance, etc., that's a different case. Now, if it happens during one calendar year, So we counted once, like this is the TB patient where the new episode had started, and it will be considered as one instance, as one case, one patient, and it will be the bacteriologically confirmed case. Because in case of failure, we just start the new episode of treatment without re-registration of the patient, without issuing the new ID code, etc. So in our registry, this patient will be under the same code that was issued and assigned to that patient from the very start. But in other cases, yes, I agree. So it can be just one case, which becomes the bacteriologically confirmed. Maybe it will not be, exactly like that. We'll see the new recommendations of WHO, but we'll see. I think this is how it should be. At least this is how I think. But today, we need to ensure that these cases are introduced into the database and they should be re-registered and reclassified as bacteriologically confirmed. Now, what are the classification groups? We know that we have the classification based on anatomical site of disease, as well as the history of previous TB or HIV status, and the drug resistance. Now, let's review each group separately. The classification based on the anatomical side, we all know, and I feel a little awkward to talk to you about these things, but again, it's just to remind ourselves, and then we can pay more attention to nuances. Now, the TB of pulmonary tuberculosis refers to any bacteriologically confirmed or clinically diagnosed case of TB involving the lung, parenchyma, or tracheobronchial tree. Now, military TB is classified as the PTB because there are lesions in the lungs. Tuberculosis intrathoracic lymphadenopathy or tuberculosis pleural effusion without radiographic abnormalities in the lungs constitutes a case of extrapulmonary TB. We know that there are new recommendations about TB treatment in children. So in adults, it remains the same, but in case of children, intrathoracic lymphadenopathy is classified as the pulmonary TB. But in case of adults, the definition remains unchanged. Extrapulmonary tuberculosis refers to any bacteriologically confirmed or clinically diagnosed case of TB involving organs other than lungs, like pleura or lymph nodes or abdomen or genitourinary tract, skin, joints, bones, and meninges. A patient with both pulmonary and extrapulmonary TB should be classified as a case of PTB. We classify them as a pulmonary TB. Now, classification based on history of previous treatment. Sorry, a question. Yeah, we said that in case of children, the intrathoracic lymphadenopathy shall be considered as the PTB. So that concerns any specific age group or from 0 to 18? If I remember, it is from 0 to 18. Until 15. Yes, it can be. I do not remember exactly what is the upper limit. But this will be considered as the PTB, and so we need to vigorously work on these issues. All right, let's see. Well, it's good that the number of such cases in our countries will be really very small, and that's a good thing. So at least we hope that it will, as the PTB as assigned. So how many children do you have, or how many cases annually do you have in your countries for children from 0 to 15? Somebody says 10, somebody said around 500. But the ratio will not be large, really. I don't think it will lead to drastic changes. But at the same time, WHO recommends to use the rapid diagnostic methods, and in children, for instance, they say that we probably need to use this tool, if I had it right. And if this about the intrathoracic TB, then, you know, there may be problems, it may not be swallowed or something, but I do agree with you that it will reduce the percentage of the bacteriological confirmation. I don't hear if anybody is speaking there without the mic. I'm sorry.
Да, я тоже так помню, что нету
Yeah, this is how I remember too. Maybe the upper age limit is not clearly identified by all countries, identified on their own, but for some of them it is the age of 15, some of them say it's 18, so it's identified differently.
Важно рассматривать эти годовые
we really have to
processes in the lungs. It's another definition. But for the pulmonary TB, we have no differences in the age groups.
Yeah. So the age 15 лет, она имеет большое значение для вот определения.
Yeah, so the age of 15 really matters for the definition of extensive pulmonary disease, but to identify the form, whether it's pulmonary or not, I don't think we had it, children. So for children, I mean, these countries independently and on their own identify the upper age limit. Okay, let's move on. Classification based on history of TB treatment. We have two big groups, new patients and previously treated patients. The new patients are the ones that had never had been treated for TB or have taken their anti-TB drugs for less than a month. And as to previously treated, these are patients who received the anti-TB drugs for a month or more, and they are further classified by their outcomes of their most recent course of treatment. And we see here how it is being
объявлены вылеченными или лечение было завершено в
конце treatment after loss to follow up and other. And you perfectly well know how it is. So it can be the true relapse or the new type of the TB due to reinfection. And so we never said, was it the true recipe for relapse or the infection or something like that. But according to information that was shared with us, and the new guide will have 3 examples of recidives, and in English they sound like that: recurrent tuberculosis,
показать recurrent, relapse and reinfection. То есть recurrent, relapse,
relapse, recurrence, and reinfection. So for recurrent, I don't know the correct terminology in Russian, but I hope that our colleagues from the WHO will give us the exact terminology. So it looks like this, that it will be done like that. And of course, the countries that do not have the genetic test of the first samples and then residual bacteria, etc., we won't know is it the reinfection or the relapse. And this is why we use this term recurrent. So it will be just a general term. But if the programs have the possibility of differentiating the relapse and reinfection, then of course we need to use it. But the general term will be recurrent. Yeah, it's like the repeated. Yeah. The next definition is the treatment after failure. And these are the patients who've been previously treated for TB and whose treatment failed at the end of their most recent course of treatment. So with the failure of treatment, simply saying, treatment after loss to follow-up. They are patients who have previously been treated for TB and were declared as lost to further supervision, and as well as other previously treated patients and those who have previously been treated but whose outcome has not been documented.
Что это или их должно быть очень мало, да? Это те случаи, которые.
So these are cases which is impossible to identify according to above-mentioned definitions, and those whose results are unknown because they are not undocumented. So with this long-term system of surveillance, monitoring and evaluation, etc., yeah, we in fact would have very few cases like that. They're not documented, etc., because the system works for quite a long time now, etc. So it can be the case that, from beginning of 90s or something like that, so before the system started functioning in general. So maybe the person would say that was treated, say, back in 1986, or we cannot find patients in our archives or registries, be it electronic or manual, so where we don't know the real results of the previous treatment. But I don't think we'll have many patients like that. Now, classification based on HIV. One question, if I may. So if the patient was treated for less than a month and then the patient disappeared and then he comes with the active TB, will he be considered as a new case or the loss to follow up? So this is again, it's all about the outcome of the treatment. Now depends and when the patient was undergoing treatment in the first episode, so what was the expected outcome? Now, according to new definitions, the patient that has been registered as the TB patient and who didn't start, and then lost to follow-up. So when he comes back, say, will he be considered as the new case? So if it's in incidence rates, then it's a new case, right? So for the program, yes, for those who were treated for less than a month, then of course they are considered. But so there are two factors that basically define everything. One factor, this is the factor of treatment, and this is, so stands higher than the episode of the previous treatment. Yes, please. So when it's the loss to follow up, so it's again about the outcome of the treatment, and there should be
So there
2
should be
months
2
in a row.
months in a row when the patient is the treatment, and after that, the result of the treatment will be lost to treatment, lost to follow. Well, we've had cases when the treatment for TB treatment, treatment was, for example, stopped for pregnancy, and then the patient is discovered. So what do we do then in such cases? So according to new definitions, that would be considered as failure of treatment, because there are no recommendations for stopping treatment during pregnancy. But, well, so you can reduce or change the drug, but if the condition of the patient does not allow you to do so, it means that this regimen method of treatment was not right, and this will be definitely failure to treat. So if the well, in any case, it's when the treatment was not brought to the end, so it was stopped and some different episodes started, which means that it will be defined as failure. Okay, classification based on HIV status. So HIV positive TB patient is a patient who has a positive HIV test. In that case, the patient should be included to the register before the treatment starts. So this means that we have rapid methods of diagnosis, also, and in case of registration of all cases with no regard to form or localization of TB. The deposit. So a person, HIV positive person with a TB diagnosis is in any case an HIV patient with TB. So HIV negative TB patient is any patient, any bacterial confirmed or clinically diagnosed case of TB who has a negative result from HIV testing conducted at the time of TB diagnosis. So any HIV negative TB patient subsequently find to be HIV positive should be reclassified. So all the patients, even those who already started the treatment, and only after that they were diagnosed HIV, they should be also reclassified. How shall we do that? How we do it in the system? Because there are systems that allow for changing some answers that have already been filled out. That's a problem that we have to solve as program. So HIV status are known to be patient, any bacteriologically confirmed or clinically diagnosed case of TB who has no result of HIV testing and no other documented evidence of enrollment in HIV. So if the patient's HIV status is subsequently determined, he or she should be reclassified accordingly. So, or if HIV negative status was found during the person should also be referred. So classification based on previous TB treatment. So this classification used for MDR RRTB patients. So we might have new RR patients. So among previously treated, we used to have two categories previously related to the treatment regimens of the patient. So I think it will be the same, but the first line drugs shall be replaced by the drugs for risk-resistant, treatment of risk-resistant and risk-resistant. So MDR patient who previously took anti-TB drugs of first line. So we already know that moxifloxacin is a drug which patient took, and this was a patient who underwent a 4-month treatment. So for unsensitive, but previously this patient took drugs for sensitive tuberculosis. So this classification with this guideline will also change because
в это время они правдивы, то есть они
well, at that moment they are valid and there's nothing unclear. So by now it is valid and nothing unclear in there, but with this updates and changes, then method will not always be valid because we will. Yes, for example, for the patient monoresistant acid, we will also start using this. So these definitions will be rewritten or changed anyway. So classification based on drug resistance. So we all know very well this is monoresistance to one first-line anti-TB drug. Call it drug resistance. This is resistance to more than one first-line anti-TB drug other than isoniazid or rifampicin. Isoniazid resistant TB, which is a TB caused by Mycobacterium tuberculosis strains resistant to isoniazid and susceptible to rifampicin. So that can be so rifampicin resistant TB or RRTB is resistance to rifampicin detected using phenotypic or genotypic methods with or without resistance to other anti-TB drugs, which includes any resistance to rifampicin. That can be monoresistance, multi-drug resistant, polydrug resistance, or extensive drug resistance. So any case which is resistant to rifampicin, mono, poly, multi, XTR, or whatever, this is a one big group which is rifampicin resistant, which includes all potential cases of rifampicin resistance with different profiles of resistance to others. Multi-drug resistance, this is resistance to at least both isoniazid and rifampicin, and multi-drug or rifampicin resistant TB. This is 𝗵𝗲𝗃𝗃. So this is a term which is group 𝗵𝗲𝗃 and 𝟃𝗲𝗃 cases together as 𝗵𝗲𝗃. This is used also for definition of all cases with at least rifampicin resistance. As to XDR so many colleagues that are here might remember and know that definitions, they have changed during the years, and this slide shows us the chronology of amendment of this definition of HRTB. So it started in 1990s when for the first time, well, maybe not for the first time, but when the programs started detecting and revealing the TB bacteria strains which are at least resistant to rifampicin and isoniazid. In 2006, there were early definitions that 𝗵𝗲𝗃 with further resistance, 3 or more of 6 main classes. At the same time, these were the aminoglycosides, polypeptides, fluoroquinolones, etc. So this was the earliest definition of XDR-TB, but very soon, and it was in October 2006 when it was the TB was revealed that it's resistant to any fluoroquinolone alone and to at least one of 3 second-line injectable drugs, in addition to multi-drug resistance. So the same, yeah. So there was this consultation meeting in October 2006 that was organized by WHO to establish definitions for XDR and XDR-TB. So this is a report of this consultancy meeting. I'm showing this because this is the only document that exists and that provides information about new definitions. So far, we don't have the guideline for definition. Well, it was published in 2020, but these terms can already be seen in the part where there are definitions, okay, where we have definitions at the beginning of new guidelines. So in this case, it means that from 2021, the cases are determined according to definitions, these new definitions, XDR and XDR. So why do we need these changes? one decision was that we reject injection drugs, and the previous definition included resistance to injective drugs. So, resistance to trachinolones also linked to a decline in favorable treatment outcomes and leads to either an important choice between the shorter and longer regimen. So previously we did not have this pre-XCR term, but then we agreed that XCR was resistant to at least one of the three injection drugs, and pre-XCR that was resistance to either trachinolones or injectable drugs. So if these cases were defined as pre-XCR, but now the injectable drugs have lost their meaning, their priority ranking over the and were replaced by other more effective agents. Well, trachinolone is used for triage, so that is why it was necessary to officially introduce this definition of pre-XDR TB plus resistance to the 𝗿𝗲𝗀𝗋. This is much more rare, but we already have reports of that. And now the drugs that we use for all groups of TB patients, they include the 𝗿𝗲𝗀𝗋, isoniazid, and it is very important. So this and everything. So the resistance to these drugs was not taken into account by older. So if we look at all definitions of XCR, trachinolone or any injection drug resistance. So if there is sensibility to so
И я думала, что это
So I thought a lot about that, and I thought that this was a limitation of this new definition, but then I changed my mind. I changed this attitude because yes, I thought it was so good that we meet patients who are susceptible to trachinolones, but they are resistant to other agents. Who are they? They are not classified. Yes, they somehow are fallen out of this classification, but in such cases, well, before that, resistance to linezolid, they are patients who are resistant. So, and this we know. So before that, this definition, this 2020 definition, before that, we did not apply this to all. But if you look at the time frame, by that time the definition was right. But now I don't know how it will be because we are introducing 𝗵𝗲𝗿𝗲 for rifampicin resistant, for trachinolone resistant patients. But if this is previously treated patient, but if this is a new patient, then there are so strict requirements. If the a patient used to receive those drugs, we have to make sure that they are susceptible to these drugs, and the algorithms already include that we have to test the patients who are susceptible to trachinolones And we will see the patients who are resistant to beta-quiolins, for example, so what would be the definition for them? So if this did not change the treatment regimen, I would say, okay, never mind. But if we know that if we know that the patient is resistant to beta-quiolin, that this drug is not suitable anymore, for that patient, we will need a long-term individual regimen. No short regimen can be used because beta-quiolin is the key drug. And so with the recent recommendations that were published in 2020, December 2020, how to deal with these definitions, I don't know. So, so before that, this definition was okay. Well, the same is the situation of 𝗵𝗶𝗿𝗀 because we revealed cases of patients who are susceptible to rifampicin but resistant to 𝗵𝗶𝗿𝗀. So what do we do then? What is the regimen we start? Do we start the susceptible regimen because all the 4 drugs are effective? So what that the patient is resistant to 𝗵𝗶𝗿𝗀. So in this case, we don't have any definition. So this is not pre-XDR, this is not XDR, this is not resistant. This is acceptable patient, but he has this resistance to quinolone. But this does not change the strategy of treatment. All 4 lines of drugs are effective.
Также и
If this is isoniazid monoresistant, well, as to isoniazid resistant, so since we do not have such a definition, so is isoniazid resistance is monoresistance? Yes, yes, that was the way it was used previously. But if it's isoniazid resistant plus other, yes, this is poly, but with HRTB. But the name of the group is mono or polyresistance to isoniazid. And if there's a 𝗵𝗶𝗿 resistance or resistance to any second line drug, then this is monoresistance. Yes, so far this is considered monoresistance. Monoresistance includes in its definition only resistance to first line drugs. So tirazinamide, for example. Yes, it does not include the resistance to second line drugs. Well, yes, because sometimes our doctors they just mix them up. Yes, but there is a huge difference because due to resistance to beta-quiolin or linezolid, we cannot start the treatment that we started in case of propranolol susceptible tuberculosis. So, according to new definition, so pre-XDR TB caused by Mycobacterium tuberculosis strains that fulfill the definition of MDR TB and which are also resistant to rifampicin at least and any fluoroquinolone. So XDR-TB and XDR-TB is the TB caused by Mycobacterium tuberculosis strains that fulfill the definition of MDR-TB and which are also resistant to any fluoroquinolone and at least one additional group A drug, which is beta-quiolin or linezolid. And now it's time to get acquainted. Okay, so everybody knows that, but to look once again at updated definitions of treatment outcome, not only drug resistant, but also drug susceptible tuberculosis. But here we see this evolution. DRTB treatment and all the outcomes of treatment, they were different adaptations of definitions, etc. However, standardized definitions were published only of 2006, the DRTB outcomes, yes. And MDR, okay. So we call them MDR. In 2006, WHO published PMDT guidelines, and in these guidelines there are some slight some slight changes to the category of defaulted, and then the definitions and reporting framework document was updated, and in 2020 we already had new recommendations for DRTB treatment, and the same year there was this WHO consultation for definition of new outcomes of treatment. Well, the consultation group that worked and this consultation report of WHO, they had the following tasks. They wanted to follow some common principles that these results, outcomes of treatment were applicable to both DSTB and DRTB and to different lengths of treatment regimens. So this group wanted to come up with definitions that would be applicable to all cases of TB, not separately for DR or resistant, but all drug resistant, but also for all regimens of treatment. Also de-emphasizing the traditional division between intensive and continuation phases. So previously the outcomes of treatment were very much dependent upon the phases, intense phase, lengthy phase, etc., prolonged phase, etc. But the new regimens do not have such divisions based on intensity. So DR does not have such divisions. So these outcomes should be applicable in these cases as well. Also, taking into consideration the use of appropriate diagnostic for treatment monitoring, to have an opportunity not to wait some 15 months when the material taken on the third month and then on 6 months have some results, etc. So among acceptable patients for monitoring of treatment, not bacteriological conversion, but for definition whether there is of sustainability with in case of positive results of treatment, and we can already use rapid methods which will allow us to quickly know about this. So also having clear parameters for defining treatment failure and ineffectiveness by a decision to change or to stop treatment, or by reliable evidence for non-response. And these outcomes should be practical for clinical and programmatic monitoring of physical anti-TB. So what were the challenges for implementation of the previous DRTB outcome definitions? Well, applicability for regimens with shorter duration, which is so our schemes now are the regimens are already 6 months long, and the oldest TRTB definitions were 5 negative samples were taken with 30, at least 30-day interval, etc. But the whole treatment is last 6 months, so it's not applicable anymore. Of course, it was not realistic to use these definitions. Also, previous outcome definitions depended upon the intensive or continuation phase that no longer apply to most of all oral regimens. Also, with the lack of reliable and universally applicable biomarker for treatment monitoring, a clear definition of bacteriological conversion or reversion is needed to inform continuation or modification of treatment regimen, and previous treatment outcome definitions were different for DSTB and DITB, which left to challenges for programmatic implementation. So you remember that we still used of all definitions of outcomes, and of course they are different for successful treatment, for failures. These definitions will be within these categories of out. What were the changes? What have been the changes? So significant changes were
ineffective treatment also has been added, and the new definition was added, which is the sustained treatment success. So I would say the treatment without the recidives, I would say that this is the sustainable success that remains as a success after the 12 months after completion of the treatment. Some changes have happened in the treatment completed, in the definition of died, and in the definition of loss to follow-up. No changes are introduced to definition of treatment success and not evaluated. Now let's look at the definitions themselves. And then you look at the nuances. Since all these big changes happened to the ineffective treatment or treatment failed, let's look at this definition first. Now, for today, for sensitive as well as resistant patients, the failed treatment, a patient whose treatment regimen needed to be terminated or permanently changed to a new regimen, option, or treatment strategy. I will quickly go through them and then we will talk in details. So now cured, a pulmonary TB patient with bacteriologically confirmed TB at the beginning of treatment who completed treatment in accordance with the national policy and protocols with evidence of bacteriological response and no evidence of failure. And in following slides, we'll see what is meant in the evidence of bacteriological response. Now, as to the good, I want to draw your attention to the fact that it can be identified in the pulmonary case. So in a non-pulmonary case, if it's not bacteriologically confirmed, then it cannot be considered treatment because of the impossibility of monitoring. So cured, it shall be a pulmonary TB patient. Yes, sure, I didn't hear what they say. The treatment completed. A patient who completed treatment is recommended by the national policy whose outcome does not meet the definition cure or treatment failure. Died, a patient who died before starting or during the treatment. It's written in blue because there are some, insignificant changes, but still, and majority of problems identified died just like that anyways. So it's not only about dying during the treatment. Some programs which had relevant systems of monitoring and e-systems that recorded any cases of TB, notwithstanding the started treatment or not, because usually the system records those who have started treatment,
Информацию
and the systems that include information about individual patients with confirmed TB who died before the start or during the treatments. They were reported actually, but not all of them. Now logs to follow up patients who did not start treatment or whose treatment was interrupted for 2 consecutive months or more. Yes, Anuj, please. About the cured cases. So if the patient from the very start had for 𝗵𝗵𝗿𝗀𝗀, so by the end of his or her treatment, will it be considered as a treatment completed or cured? Because we won't have other lab indicators and tests because we didn't have it in the beginning. Well, you see, we don't have any particular or specific instructions on that yet. And the impression is that it will be considered as cured, so it will be considered as bacteriologically confirmed as the gene expert positive, and if the microscopy and the culture would be negative, then it would be considered as treated. In the pulmonary case, yes, exactly, only in the pulmonary TB case. In non-pulmonary, they will be maximum as the treatment complete.
Положительный вначале, так как у него был эксудат или как материал. Потом
if they had the accident, and if it is like with the experts, then I mean it sounds unfair. Well, yes, but they mean the bacteriologically completed pulmonary case, not the one that are confirmed. Yeah, but just for pulmonary, this is, yes, it's unfair. But the principles that have been listed in the previous slide, so that they're used in the maximum of cases, you know, in order to observe those principles, this definition should be flexible. The not evaluated, a patient for whom no treatment outcome was assigned, and the treatment success, the sum of cured and treatment completed. And the last new definition, it's a definition of sustained treatment success for use in operational research only. And the definition is that the patient that was assessed at 6 months for DS or DRTB and 12 months for DRTB after successful TB treatment, who is alive and TB free. So this without relapse or recidive after 12 months, TB free and alive 12 months, so they will be considered as the sustained treatment success. And well, of course, the programs can introduce these definitions, especially if they follow up their patients for at least 12 months, but not necessarily. But for the operational research, then all countries are included into the implementation of the short-term modified treatment regimens, and we know that the sustained treatment success will be identified according to what we have seen on the slide. Now, as to failure, that ineffective, right? So we said that it should be either terminated or the regimen should be permanently changed. And what can be the reasons for such a change or termination? It can be a lack of clinical response or response of the bacteriological response. Sorry.
Previous slide. Thank you. Это что означает? Значит,
So what does it mean? It means that we not only look at the bacteriological conversion during the treatment, but we look at the clinical results. So the patient, say, doesn't gain weight or that the weight reduces. Now, like response worsens, so there is no clinical response. Well, it can't be standardized, but we hope that there will be more standardized solutions in the guide. But we think that it will be the parameters that we look at during the treatment when we have their monthly examination to assess the effectiveness of treatment. We look at the weight, symptoms, temperature, cough, X-ray. So if there is worsening, then it means that there is no clinical response. And if the clinical picture remains the same, then probably we wouldn't say that there is response. But if it's worsening, then definitely we'll say that's the treatment. So the culture microscopy where it remained positive during the treatment, but they don't say in how many months, etc. Now, side effects. And what does happen then? We either change the regimen or we terminate or we move to the completely new regimen, or maybe some adverse drug reactions, which may become the reason for termination of treatment. For instance, if it's the patient on 𝗵𝗲𝗿𝗲 and the patient has immunosuppression or something with the eye nerve, then we will have to immediately stop the treatment as soon as it is identified. So, and 𝗵𝗲𝗿𝗲 without lisdexamfetamine does not exist, and this is a standard regimen, and it shall be administered in the recommended dosages and according to the WHO recommendations for the program. So linezolid, if it is lifted, then it is failure. So the treatment has failed. It's not that the patient failed, but the treatment regimen that we used for treating this patient, that regimen has failed, and that will be the outcome of that regimen, and it will be considered as failure. The patient may be moved to the long-term regimen without linezolid, but this particular will be considered as failure, and in the next one they will be considered as cured. And this third reason for change or termination, it can be additional drug resistance to medicines in the regimen. Colleagues, I brought some examples only about the drug-resistant TB, but it can be about the drug sensitives. You know, these examples could work. So when we say about side effects or this, adverse reactions, now some are resistant to rifampicin. Then what do? We add the drugs of the second line. Well, it happens rarely, but this regimen, in case of such regimen, we wouldn't identify it in any way or shape. But now, with this standard of 6 months regimen with the four drugs, and then, say 2 months with 2, etc. And if we started the new individual regimen after the, counseling, and in case of this particular patients, they will decide to change the regimen, it means that in this particular case, this regimen is a failure. It's ineffective. So these are some news or innovations that we have to understand and realize. So what are the changes caused by this definition? Change definitions. So say if the second month the microscopy is still positive, and in the third month, earlier we would do the phenotype, we would wait for the 5th month, we would just observe the patient, continue treatment, and if we see that in the 5th month it's still positive, then it's failure, etc. And if it was in the 4th month, that we would move the patient to U treatment or something. But now we can do the 𝗔𝗋𝗋𝗿 in the 2nd month and the 3rd month. So if the patient was rifampicin sensitive, and if the material taken from the 0 months, and we know that is in the phenotype and so the 𝗔𝗋𝗋𝗿, etc., and if material is taken in the 2nd month, shows the LPA resistance, etc., right? We can use the LPA for the monitoring or 𝗔𝗋𝗋𝗿 for monitoring of sensitive patients for increasing of course, if the microscopy remains positive, not in all cases, only in case of the positive microscopy. And then in the 2nd or 3rd month, say we get the resistance to rifampicin, then we will not continue, right? So what do? We stop the 6-month standard regimen, and according to the resistance profile, we switch them to a different regimen of treatment. It can be with 𝗵𝗲𝗍, or it can be short-term or long-term treatment for the peroral, etc. But the fact becomes the factor and the reason for termination or permanently changing the regimen. And this regimen that continued for 2 or 3 months is considered as failure. It's a big difference from what we had before, because before we would wait up until the 5th month, and only after that we would identify it as a failure. Cured. It is the pulmonary TB patient who is bacteriologically confirmed TB at the beginning and who completed treatment in accordance with the national policy with evidence of bacteriological response and no evidence of failure. And what is the bacteriological response? It refers to bacteriological conversion with no reversion. Bacteriological conversion describes the situation in a patient with confirmed TB, at least 2 consecutive cultures, where this at least 2 consecutive cultures or smears, and this is only for sensitive, only taken on different occasions with an interval of at least 7 days, and when they're negative. So bacteriological conversion, we looked at it before as well, and it should have been the reason for identification of cure. But now there's 2 consecutive cultures. They should have been taken with a minimum of interval of 30 days. And now the change in interval is there. So we now have 7 days instead of 30. So for short-term regimens especially, so imagine that if we want to complete the treatment with 𝗵𝗿𝗍𝗿 in the 6 months, and we have to do the culture every month for short-term regimes, we have to do the culture. Well, of course, if patients have it, and instead of waiting 30 days, we can do it. We can do it in 7 days. So the period reduces, so we can do it in the 5th month or a 6th month, and they repeat it in 7 days, these cultures. And the results of those cultures will be so faster results, and that will allow for that. Yes, so it will allow for having some results much quicker instead of waiting 30 days for 2 cultures. Yeah, the clarification question. So in short-term regimens, in the beginning or in the end, but I think we should do it in the end, yeah, and this interval can be 7 days, because some clinicians may understand it's that we can do it generally in 7 days. Yes, it's exactly what I wanted to add. Of course, colleagues, I said every month, cultures every month for the monitoring of treatment. We have to do it on a monthly basis, not every 7 days, but monthly. But for quick identification of the treatment outcome, we can do the 2 last ones in 7 days from one another. So we think that the guidance that will be issued will give us some additional information about the reasons why they reduce this interval from 30 days to 7. Will it be, cultures or microscopy? Well, one of the reasons will be to give the opportunity of programs to really complete the treatment faster and sooner, because we're talking about the 2 last microscopies or cultures, not to wait a month. And there can be some additional reasons which we may not know, and we'll know it when the guidance is ready and published. And bacteriological reversion describes the situation when at least 2 consecutive cultures on smears taken with an interval of 7 days are positive, and that concerns the cases which initially were bacteriologically not confirmed. So if during treatment they become bacteriologically positive, and 2 consecutives taken with the interval of 7 days if they are positive, then it will be the bacteriological reversion. And if it is so, then this case may not be considered as cured, because the criteria for cured is the evidence of the bacteriological response, and without evidence and signs of failure. And if it reverses, then it is failure, and it will be identified differently. Died and not evaluated. They died if the patient died for any reason before the treatment or during the treatment, and not evaluated. That includes cases transferred to another treatment unit and those whose treatment outcomes is unknown. However, it excludes those who are lost to follow-up. And the outcome can be at the level of the institution, at the country level, not evaluated, can be those who say left the country and moved to a different country to leave. But if it's the one institution, then so if the patient is transferred to a different unit, then for that unit, it will not be evaluated, but at the country level, it will not be considered as such, because the central level looks at the bigger picture than the particular institution, but at the programmatic level, there can be unevaluated cases, those, it will be people who left the country and therefore they don't know whether the treatment is at all completed or, whether they continue it or not. And also when there is no evidence when they terminated, say, treatment. So when we don't have any information on those, and of course the number of such cases will be really small and the percentage minuscule. And of course, it's desirable to have 0 of such cases, but it can be ensured only through the trans-border communication between different countries, where we know that patient moved, etc. And therefore, we will need to build communication with these other countries to receive information about patients. And the country should be able to inquire about it and then report. And it would be interesting to know. Now, in case of Ukraine, for instance, it will be a big number of patients like that. And in case of Ukraine, probably the numbers will be bigger, but in standard situations, the numbers shall be really small. Now, dear colleagues, I've spent a lot of your time, I've taken a lot of your time, but I here want to, at least since we're talking about monitoring and evaluation, I want to list the 10 priority indicators. And here are the indicators for global and national levels. And why? Because why do we collect all this data? Why do we have and identify standards, etc., so that we use these indicators so that they are comparable? So that we can compare data between countries, regions, etc. So the TB treatment coverage. So this is the target for 2025. As you can see, this is TB treatment coverage, number of new and relapse cases, and that were notified and treated divided by the estimated number of incident TB cases in the same year, expressed as percentage. So the number of identified cases and the number of treated. The TB treatment success rate, it is the percentage of notified TB patients who were successfully treated. The target is for the drug susceptible and drug resistant to be combined, although outcome should also be reported separately, which means that by 2025, the WHO wants the countries to have the 90% of treatment success rate, will it be in DS or DR TBs. Percentage of the TB affected households that experience catastrophic costs, and Ezra talked about it, it should be 0%. Percentage of new and relapsed TB patients tested using a WHO recommended rapid test at the time of diagnosis, and the figure should exceed 90%. TB preventive treatment coverage, again exceeding 90%. So, colleagues, what should we, what should be the coverage, and how can we, achieve that? Yes, I mean, TB preventive treatment coverage, how can we achieve that? Need to speak at the microphone so that I can hear what they say. number of people for whom the preventive treatment was indicated. That's right. And that will be done in accordance with the country criteria. So it can be children contacts, be it can be contacts of any age. So this may change, of course, and they may vary, and it will include the group that is recommended by the national policy or national decisions. Now, contact investigation coverage. And why did I ask that? Yeah, sorry, because our information systems, maybe some systems have electronic systems, but they do not provide the full information, like the number of patients for whom the preventive treatment is indicated. So if we don't have that, then how and where can we get this information? Because it is in the top 10 indicators, it's among the top 10 indicators. Why do I bring the examples? No, it's just to know where we have gaps that we need to fill. And our information systems, they are not really giving us the comprehensive information about this one of the top 10 indicators, like preventive treatment coverage, or, So if our national governor says that it should be all bacteriologically confirmed cases, they shall be examined for TB and the infections, and then the preventive treatment may be recommended, then we will know anything about it unless we have the strategy in the country that this epidemiologist goes to every house and says that it should be treated, and these are contacts, etc. So this is the indicator, and we need to get the information on them.
And this requires some changes to reporting, changes also on the level of epidemiology institutions like centers of healthcare, etc. So coverage of TB patients with testing to susceptibility to drugs. So we are doing that, and this information is available. Also coverage of so contact investigation coverage, so treatment coverage, and with new TB drugs. So all the now we use the same drugs for short-term and long-term regimens of treatment. These drugs can be used for long-term individual regimens. So this means that our information systems should collect information on the categories of regimens of treatment, so that we have this information on hand. Documentation of HIV status among TB patients. This is clear. This is linked to the basic forms for reporting and registered, and case fatality ratio. This is specifically information that is taken from the system of vital registry agents. And now conclusions. Well, although, or taking into consideration that we are rapidly implementing the new recommendations, all the updates, this also requires rapid implementation of current and updated TB case definitions. This is very important for adequate TB surveillance. So treatment outcome categories are the same across all types and the treatment regimens. The change outcome okay, not the death notifications for any reason should be done, and outcome should be also recorded in any case. It's not mandatory, but yes, it will be used for operation. And I would like to extend my gratitude to the colleagues from WHO, because I used some of their slides in my presentation. And thank you.